Shirin wears many hats. She's a nurse practitioner, and she's experienced working in a variety of specialized geriatric service programs. She's a PhD candidate in nursing science and one of our collab specialization students in aging, palliative, and supportive care here at the University of Toronto. Her research focuses on engaging older adults and their care partners with early stage dementia in advanced care planning utilizing virtual platforms. She's been working as an RA for her PhD supervisor, Dr. Kathy McGilton, at the Toronto Rehab Institute, and as a TA at the University of Toronto. Shirin participated as one of 3 facilitators in a post-event workshop for the 2020 Canadian Consortium on Neurodegeneration and Aging Partners Forum and Science Days, which was called Working Together to End Dementia, which was held in 2020. Shirin and a fellow student in 2019 received the Canadian Nurses Foundation Award Scholarship in recognition of their academic and clinical excellence and leadership qualities. She's worked as a registered nurse and a nursing instructor at the Aga Khan University Hospital in Pakistan and East Africa, as well as in Toronto's Mount Sinai Hospital and Sunnybrook Health Sciences Center. She's also worked as a nurse practitioner for Pfizer and the Scarborough Hospital, and as a geriatrics instructor for emergency services in the county of Haliburton. For the last 6 years, Shirin has been the lead nurse practitioner at St. Paul's Lamoureux Center, where she coordinates and works in collaboration with physicians, nurses, and other health professionals to offer geriatric clinical integrated care to support frail older adults to live well in their homes and community. She has a dozen publications, most with her supervisor, Dr. Kathy McGilton, from the Bloomberg Faculty of Nursing at the University of Toronto. Shirin recently founded an initiative during the pandemic called Voice Your Values. And it's a feasibility study that allows clinicians to initiate advanced care planning conversations virtually with early stage dementia patients to optimize their care plans during the pandemic. So thank you so much for coming today. And I'm really looking forward to hearing what you have to share.
Thank you so much. I have to be honest, it was so weird hearing about myself. And I thank you for that. So good afternoon, everybody. Thank you so much for sharing your lunch hour with me. I hope you all are keeping well in these crazy times. So today I will present my PhD work, a little bit of it you already heard from Ms. May. It involves a feasibility study designed for the implementation of a tailored advanced care planning intervention called Voice Your Values in persons with who are living with early stage dementia. And I would like to mention that my PhD work is informed by my clinical practice or clinical experience, first as a critical care nurse, and then working as a nurse practitioner in a variety of specialized geriatric services. At the outset, I want to give my highest gratitude and heartfelt thank you to my PhD supervisor, Dr. Kathy McGilton, as well as my committee members, Drs. Martine Pitt and Andrea Iaboni. There have been a lot of uncharted territory, and they have challenged me and guided me throughout the development and execution of this work. Of course, I would also like to thank all of these institutions for their financial support that served to validate for me that the work I was doing is important. So let's move on. Just a little bit of background. So, and I would like to request to hold on to your questions for the end, and I promise we'll have enough time. I am looking at my watch. I can talk a lot sometimes, but I'll keep looking. And I think we'll have plenty of time to have some discussion at the end. And I look forward to hearing from you. So with the changing demographics, there is an increased number of older adults than any other age cohort, not just in Canada, but all around the globe. Dementia is predominantly a disease in old age. Hence, there's an increased dementia prevalence with this changing demographics. Currently, 50 million people have dementia globally, and this number is expected to triple to 152 million by the year 2050. Furthermore, people with advanced age frequently have multiple other chronic medical conditions. And so that's commonly there in people who are over the age of 65. So in addition to age-related physiological decline that people experience, and in combination with all these chronic medical conditions, they are at high risk for increased frailty. And a large majority of these individuals live in community. Only in Ontario, over 100,000 people live with dementia in community settings with complex care needs. And deaths related to dementia have also doubled between 2000 and 2015, making dementia the 7th leading cause of deaths globally. We all know that dementia is a progressive, irreversible neurodegenerative condition with no curative treatment currently available. We are hopeful. In the last year of life, the symptom burden in persons with dementia is similar to that of those living with cancer. Yet, people living with dementia are not offered optimal end-of-life and palliative care and frequently receive aggressive and often futile care measures at the end of life. Timely advanced care planning has the potential to improve outcomes for people with dementia, such as decreased hospitalizations, increased concordance between care received and prior wishes, better pain and symptom management at the end of life, and increased completion of advanced care planning documents. Yet less than 50%, not 50, less than 40% of individuals living with dementia globally participate in any advanced care planning discussions and documenting their wishes. And as a result, the end of life decisions or decisions related to other crisis situations are left for family or friends, family or healthcare providers, which frequently lead to uncertainty, stress, and a lot of these individuals complain of guilt as well. So now that we have started talking about advanced care planning, let's touch a little bit on advanced care planning. So what it is, what is it? Advanced care planning is a complex process that involves many advanced care planning behaviors that support adults at any stage or any age in understanding and sharing their personal values, life goals, and preferences regarding future medical care. However, a person must have mental capacity to participate in these advanced care planning discussions. Whereas in those living with dementia, there's a small window of opportunity to engage in advanced care planning processes due to an impending loss of cognitive capacities to be able to participate in these discussions, hence the need for this study. Let's talk a little bit more about the rationale that I had in my mind when I was planning the study, when I was writing the proposal for this study. So it is extremely important to note that people who have early stage dementia, who are still in the early stages of dementia, are able to participate in decision making and stating their preferences with a very high degree of accuracy and reliability. However, there is evidence that they would only engage in advanced care planning discussions if it is initiated by somebody else. In a recent scoping review that I conducted as part of my PhD program, we report barriers identified by primary care providers about initiating advanced care planning discussions in persons with dementia, with early dementia in their care settings, so clinics basically. And these barriers include prolonged dementia trajectory, uncertainty about prognostication as to when the person may die because of dementia. Other reasons for not initiating these conversations include concerns about causing psychological distress and a general lack of educational and experiential preparation of healthcare professionals to engage in such conversations. There have been a decent number of studies completed on advanced care planning in the context of dementia. However, majority of these studies are completed in persons in late stage, mostly involving nursing home settings. And the focus of outcomes has been on procedural documentation, such as preferences related to resuscitation or feeding tube placement or admission to nursing home. These are just some outcomes. So there remains a lack of evidence-based guidelines to inform clinical practice, especially related to the early initiation of advanced care planning conversation in persons with dementia. Hence, there is an urgent need for prospective studies examining the feasibility, acceptability, and salient components of advanced care planning in older adults with early stage dementia who are living in communities, so that their values and wishes are for future medical care could be brought to the fore. And in doing so, that trusted individuals such as family, friends, and other acquaintances may be better prepared to make informed medical decisions in future. So I proposed Voice Your Values, a tailored intervention to promote engagement of older adults and the trusted individuals in advanced care planning early in dementia trajectory using virtual video conferencing technology. And the purpose of my study is to determine the feasibility, acceptability, and preliminary efficacy of Voice Your Values intervention in these individuals. To our knowledge, this is the first study that engaged older adults with early dementia and their trusted individuals in advanced care planning process during the current pandemic through a secure online video conferencing platform. So we are hoping that the study findings will also contribute to the development of practical recommendations for using real-time video conferencing technology for advanced care planning discussions in practice and future research. As mentioned earlier, this is a feasibility study where I'm using a single group of dyads, so that is older adults and trusted individual duo, in a pre-test and post-test design. And the recruitment happened through the outpatient clinics and outpatient geriatric clinics in Scarborough, Peterborough, and Markham areas. The eligibility for the older adults was that they are 65 and over. They had a diagnosis of early stage dementia. They were able to speak and read English. And they had a trusted individual who was at least in weekly contact with them. The eligibility for the trusted individual was that they are 18 and over. There is no self-report of dementia, deafness, or blindness. They are able to speak and read English, and they are unpaid trusted individuals. Now, at this point, I think it is important to share the impact of COVID-19 that all of us sustained. Like many of you, this current pandemic has been the biggest challenge that I have encountered during my PhD program. And to put it in perspective, I defended my proposal in September of 2019, and my study is a multi-center study requiring, and it required me to get REB approval from multiple places. So it took several months for final approval, and then COVID happened. So after some time of sulking and all that, we decided to go virtual. Prior to that, I was supposed to meet with people in person, either in their home or in the clinic setting. Anyways, everything went through. It took an extra couple months for approval again through all these places. And finally, I started collecting data or implementing Voice Your Values with the individuals in August of 2020. The plan was to recruit 35 dyads. However, we stopped data collection just 2 weeks ago at 20 dyads due to challenges related to recruitment, as all these clinics have been much affected by pandemic-related changes. Many of the staff are relocated to other places. So that's just to give you an idea. So now that we had to move everything virtually, all the procedures for this study were conducted using video calls through with the use of Microsoft Teams platform. The consent procedure. So these are the 5 video calls that happened as part of this study. First was the consent visit. The second was for baseline measures collected by a research assistant. And the dark blue blocks, or whatever they are called, are the actual delivery of the Voice Your Values advanced care planning intervention by myself. And the last one, again, is for post-intervention data collection by the research assistant. I want to touch a little bit on the theoretical underpinnings that informed the design of this intervention. So it's basically it's the trans-theoretical model of stages of change and the representational approach to patient education. They were the 2 that were used as a lens for designing this intervention. Representational approach to patient education proposes that individuals have mental representation of their illness or health problem, and that it is critical to understand these representations because they affect whether or not individuals accept or reject new information, and whether this new knowledge will translate into any behavior change. Remember, advanced care planning is a set of behaviors, right? Also, understanding these representations served as a foundation for me, the interventionist, to provide individualized, tailored education to the diet. And then the trans-theoretical model posits that behavior change requires change in several factors or processes, such as knowledge or understanding of the importance of the behavior, contemplation of engaging in the behavior, which is advanced care planning, self-efficacy to complete the behavior, and readiness to complete the behavior. So this basically informed the design of the intervention. So Voice Your Values intervention, let's talk about it a little bit. This is the screen that people would see when they connect with me to participate in this intervention. In the first intervention session, which is about 45 to 60 minutes, again, everything is virtual. Sometimes people were living together, so they connected together. Sometimes older adult lived separately and a trusted individual lived elsewhere, and we all connected using the video call. It involved older adults and trusted individuals engaging in conversation to identify their representation, their understanding of dementia and advanced care planning. As a result, I was able to identify gaps and their concerns. Everything was audio recorded, and I used something called a Spikes protocol and gentle persuasive approaches to engage them in this conversation and giving them the opportunity to talk about these. In the second session, by then I had listened to the audio and planned an education presentation for them. So again, this session lasted for about 60 to 90 minutes, and it happened within 1 to 2 weeks of the first intervention session. We met virtually again, and I provided them tailored education. And after that tailored education, I coached the older adult in identifying their values and wishes for future healthcare. And for that, I used something called Thinking About My Wishes for Future Healthcare, which is a great resource from the Speak Up Advanced Care Planning campaign in Canada. I would like to mention at this point also that in order to design this intervention and even the consent form and everything, I did seek feedback from an individual with the dementia, living with dementia, some caregivers or care partners, and some clinicians as well, and not just the intervention and the consent form, but all the measures that I'm using in this study, so that I can get their feedback in terms of any changes that they would suggest, and those changes were made prior to the implementation. These are all the outcome measures that I collected as part of this study. In terms of the feasibility, we looked at recruitment, retention, intervention fidelity, and acceptability of the intervention by both the older adult and the trusted individual. The primary outcome was surrogate decision-making confidence scale, and we want to see if it will increase as a result of participation in this study. And some other secondary outcomes included advanced care planning engagement survey completion by older adults to see if they moved upward on their advanced care planning trajectory. And dementia knowledge, if that increased in trusted individual as a result of participation in this study. And finally, psychological distress that was collected from both older adults and trusted individuals to see if participation had any impact on their psychological distress. So now I would like to share some preliminary findings. As I mentioned, the data collection just ended about 2 weeks ago, and I'm still going through the analysis of the data, but we have some preliminary findings that appear quite promising. So we had identified that the success measure criteria for this feasibility study would be looking at feasibility and acceptability outcomes, right? So we were hoping to recruit about 60% of the eligible participants. And this is where I had some issues. So I got a referral for 46 individuals. But when I connected with them, only 21 agreed to participate. So that is not 60, but 45%. And the reasons were mostly related to not having access to a device. The trusted individual was not able to travel to the older adult because of the COVID-related social distancing measures, and the older adult did not feel comfortable or did not have confidence in participating without anybody present with them. So that was a bummer. But in terms of retention, I was hoping that 85% of those who agreed to participate will stay and complete the trial, but it was 100%. So that was just amazing. In terms of the acceptability, we used a treatment evaluation inventory questionnaire, and we were hoping that about 75% of the respondents, both older adults and trusted individuals, would score more than 53 on this inventory. But 100% of the trusted individuals scored more than 53, quite higher than 53, which is amazing. And in terms of the older adult, 83% scored more than 53, which is also amazing. Then I want to show you some preliminary results in terms of those 3 measures that we talked about. So substitute decision-making confidence, which is this first one, SDMC. The second one is K10, which is psychological distress. And the last one is DKAT, which is the dementia knowledge assessment tool. So in terms of substitute decision-making confidence, you can see that about 13 individuals, 13 trusted individuals had increase in decision-making confidence after the participation in this study, whereas 5 had no change, and in 2, it went down. In terms of the psychological distress, about 15 trusted individuals. So this data is just related to trusted individuals. I haven't analyzed the older adults data yet. But we see that in terms of the psychological distress also, 15 had decrease in psychological distress after the participation, whereas 2 did not have any change, and 3 had increase in psychological distress after the participation. In terms of the dementia knowledge assessment, there is so it looks at the number of wrong responses, and you can see that about 10 have decreased number of wrongs, and so on and so forth. These 2, the decision-making confidence and psychological distress, appear to be statistically significant as well. So the next one that I want to share with you, I hope you can see the whole thing. This data is coming from a virtual experience questionnaire, and This was previously used in another study using Zoom as the tool for video conferencing. We got permission to use it for this Microsoft Teams, and we have the data I'm presenting here is related to sound quality, which refers to the ability to hear participants. Video refers to the ability to see participants or to see the researcher, vice versa. And lag looks at the frequency of lag in live feed, in live audio or live video. And they were all, these two, sound and video, were rated on a 5-point Likert scale. So 1 means none of the time they could hear or see us, whereas 5 meant that they were able to hear and see us all the time. And lag experience, 1 is equal to none of the time the experience as well. Same goes for the lag as well. So researcher ratings. So we had, myself and the research assistant, we had about 80 encounters with all these individuals, because remember, there were 4 video calls that we completed after the consent visit. And it seems that the sound quality and the video is, we have both rated it pretty high. So 4.8 to 4.7 out of 5, which is pretty good. And lag wise, it's just 1.3. So we basically did not experience that as much. And if you see participants rating, which is older adults, so 20 older adults, and then participants rating trusted individual, again 20, and they have also rated pretty high. So number wise, it looks pretty good in terms of their virtual experience. I do want to share also their responses, their qualitative data. So this virtual experience questionnaire also has some qualitative questions that asks about their experience, their challenges, and if they would prefer another method for participation with any specific reasonings. So I hope you could read it. So this is some of the quotes from older adults and trusted individuals. As you can see, one older adult, the first one here, they are saying that, well, I do have hearing problems, so I'm always nervous if I am going to hear you, but I do hear you okay. I guess one of the challenges is it is something new. And the other thing is, when I sit face to face with someone, you read their faces, you read their eyes and everything else when you're talking to them. So they thought it worked out okay. Another one says it was a lot of fun. I would enjoy learning more about computers. And the next one says, I find it very good because I am computer literate. I don't have to worry about doing this sort of thing. But they also are saying that we do know some people who barely have emails, and they are finding the COVID-19 thing very frustrating. And then in relation to the trusted individuals, some of them said that because of COVID-19, it was not bad. It was the same as sitting in an office and sharing the information and receiving information. And they're saying that they found it even more better because they had more privacy, because they were in their own home environment. And the second one is interesting. They're saying that there were some difficult topics, and they found virtual mean better because they were not really sitting in the presence of somebody, but they were actually talking to somebody virtually who were not present in their space, and they thought it was easier for them that way to talk about these difficult topics. And the last one is, I honestly liked it. Doing this is good. For one thing, I didn't have to get him dressed, to hurry him into the car, to go to a meeting, to go to a hospital where I have to pay for the parking. And then there's some other ones that are very insightful as well. That one, like she's saying that if I did not have my wife to help me set it up, it would be a major problem. The other one is saying that I did not grow up with the internet, but my kids were there, so they sort of helped me. One trusted individual is saying that they enjoyed the virtual experience, but but being in their home, she had difficulty keeping the privacy because people were coming in and out. And then that they could not really enlarge the PowerPoint slides, so they could not read some of the stuff. I would like to mention, though, that all the PowerPoint presentations were sent to these individuals for their reference. But through all these individuals, when we asked them about any other method that they would have preferred, so most of them, of course, are saying that in person would have been better, but this worked well. But majority said the telephone is not a good idea for having such kind of conversations. But some of them also mentioned that in person provides you an opportunity to touch and provide support that way, look into their eyes, lean closer. So those are some of the things that people sort of missed. Finally, in terms of my experience working, providing this or doing this research virtually, so of course I had a decreased number of potential participants, but I don't think it was related to having the virtual research, but more so it was because of the pandemic that caused a lot of issues in relation to participation or number of participants that I could recruit. There were factors related to the clinic, there were factors related to older adults, there were factors related to trusted individuals. So it was a multifactorial issue, as a result of which I did not get the expected number of participants. Lack of device was another issue. And that I also felt that I could not support the individuals the way I would have supported if I was sitting with them in having these difficult conversations that does not usually happen. Screen exhaustion was another thing that just sometimes looking at the screen, I'm sure all of us can relate to it. And the other thing that was a challenge was that when I was sharing the presentation with them, I could not really see some of their faces, or they would be displayed at the bottom, which was really little. So that was another thing that I did not enjoy. But at the same time, I felt after each of these conversations, I felt a sense of accomplishment and joy, and based on what they told me that they felt. So at the end of it, I think it is a success story, and we should look into more opportunities like such, where people can engage in advanced care planning conversations. Much of the healthcare is anyways provided virtually, so why can't we have advanced care planning conversations using this mode? So that would be it. Thank you so much for your attention, and I would be more than happy to take any questions that you have.
Thank you. Oh, I'm trying to do this. Yeah, thank you so much. Very interesting. I just have a comment before I open the floor, which is we also have the same issue of trying to have our PowerPoints and see people. And it turns out the magic solution is having two screens. So you can have one screen that just has the people's faces on it, and then the other what you're presenting. So you might find going forward that helps, because it certainly helps with teaching to be able to see them both. So
yeah, thank you so much. I'll look into that.
All right, great. So any questions or comments from everyone? I see we now have 11 people online. So yeah, I don't see any chat, but please just unmute. And also we'd be happy to hear your experiences with advanced care planning as well, remotely or in person. So
of course, I can stop sharing now, right? So
yeah,
I'll do that.
Great. Let's go to gallery view. Okay. Any comments or suggestions or ideas? I mean, I also want to make a comment that, you know, considering you started this at like the worst possible time ever for starting a presentation, congratulations on, you know, having viable findings during the year of the pandemic. I can only imagine how you must have been pulling your hair out for a good portion of it. So. So any other comments or ideas?
Yeah, I really would like to hear ideas as well.
Okay, some of the people have sent comments instead in the chat, so let me just speak to that. I'll read it out. First, from someone at UHN, thank you. That was a very valuable presentation. And from Joanne, I appreciate all the work that went into this and your time in presenting. It's a vitally important topic, and I'm glad that you found some success. So kudos. Margot, do you have a comment? And then
I want to know who chose the trusted person and how were they chosen?
Thank you. That's an excellent question, Margot. It's the older adults. They were supposed to choose the trusted individual.
Was it someone they lived with usually?
No, it varied. It was mostly a child or a spouse, but it was chosen by the older adult. They had to choose them. And the whole idea is that in the early stages of dementia, people have the capacity to be able to participate in such conversations. So they should be having the choice to choose the person that they would like to include in this study. But I was also cognizant of the fact that this individual that they bring with them may not be somebody who would fit into the substitute decision maker category or the hierarchy as laid out by the Health Care Consent Act. So if that was the issue, I would bring up a conversation related to completing power of attorney documents.
Mm-hmm. That's what I was thinking. It was one of those people that you had designated as your healthcare
correct
alternate. Yes.
Yeah, I think Sarah had something.
You're muted.
Oh, you're muted.
Wait, you're still muted. Bottom left. Usually, yeah.
Sorry. So sorry.
Yeah.
Hi, thanks a lot for the presentation. It was great. And I may have missed this at the beginning, so forgive me, but what sort of areas of advanced planning were you discussing with them?
Yeah, that's so as I mentioned earlier, and talking about the advanced care planning, that it's something that includes a variety of behaviors. And it cannot be completed in 1 or 2 sittings. So that I had in mind. So my focus was to talk about their values and wishes for their future care. And that was the only focus. And that's why I used that document, thinking about your wishes for future healthcare from
Did you have any sort of, were there any clusters of values that were really important to people?
It's interesting you ask, and yeah, it is very comparable. So people were very clear that if they are not able to engage with their surroundings and people they love, they would not want to have any aggressive treatments. That was one of the things. The other thing is that people were very clear that they want their decision makers, their substitute decision makers to make decisions based on the values and wishes expressed, and so respect their expressed values and wishes, and not make decisions based on what they think is right. So those are some of the things. Nobody wanted any unnatural means of feeding if they are not able to feed on their own. Nobody wanted to live in a vegetative state. So those were, very comparable, similar.
Sorry, did anybody ask about medical assistance in dying in this context? Yeah.
Oh, absolutely. Yeah. I think at least 5 people, I don't remember exactly, but at least 5 people wanted to learn more about medical assistance in dying in the context of dementia. So you know how in the first session, I would provide them with an opportunity to talk about their understanding of dementia and advanced care planning. That's when it would come up that they want to learn more about medical assistance in dying. So in the second session, I would provide them with education on that. And this is a tricky topic for those living with dementia. But yes, people were interested. So now that the conversation that has been going on in relation to its applicability in those living with color impairment, it only makes sense. but yeah, advanced consent and all that is tricky. But yes, people did want to know more about it.
Thank you. Thank you.
Great. I'm just going to add in some comments. There's some interesting comments. Well, lots of different ones anyway, but so Kristen says, I work in long-term care and initiate these conversations, but it is definitely uncommon for the conversations to have already occurred. It's so important to happen early on when the individuals can share their own wishes. And earlier she mentioned, thank you for your presentation. This is promising. It's been difficult to have these conversations lately because of the pandemic and the restrictions. So
yeah.
Good observations.
Absolutely.
And there's some other comments. Anwar is asking, says, thank you for your important research and presentation. Can you tell us how the participants break down by gender?
I won't be able to give you an accurate answer, but what I can remember is it was very equally distributed. I think I had almost same number of males and females, older adults, and in terms of the trusted individual, I would say that the majority. It was interesting to see that not just the sex, but the relationship between the older adult and trusted individual part was interesting as well. So about 50% of my referrals came from Scarborough area, and about the rest, the other 50% came from Peterborough area. And it was interesting to see that those that came from Peterborough area were all couples, and were whereas those that came from Scarborough were the children or the child of the older adult. And the age was quite different. There was some difference in the ages of those from Scarborough versus Peterborough area. Demographic ethnicity was quite different. It will be interesting to see when I do a proper analysis of these demographic differences. So I think I'm not able to answer your question very well, Anwar, but I am I'm looking forward to seeing that data as well. I'm not there yet.
All right, so that leads the next two comments. So Joanne was saying how interesting it'll be to hear what the patient outcomes and comments are. And Julie commented, did you find that participants changed their perspectives on what they would choose as advanced care planning from the beginning of your intervention to the end? So I know you haven't done the whole analysis, but just anecdotally, did you notice some changes?
So, so we were not really looking at changes. We were looking at their engagement in advanced care planning conversations, right? Mm-hmm. So all these individuals participated because they had not engaged in such conversations as such. So, and all of them felt that this, so I can remember one participant said that we needed a kick in our butts to talk about these things because it's so valuable. So, so there's no change, but everybody moved forward in terms of their dementia trajectory from where they were to where they went. Another interesting thing that I saw was trusted individuals got the opportunity by participating in this intervention to ask questions to older adults. And many of them were surprised at the choices that these older adults were making, or their comments in relation to aggressive treatment, hospitalization, feeding tubes, so many different things. Many of them shared what they would want at the end when they are about to pass away, in terms of like what their environment should look like. So there were some surprises for trusted individuals for sure, but no, we didn't see changes because people did not have such conversations before.
Fantastic. So just read one more comment from Julie, and then we'll have Sarah's, will speak up. So it's just so important to facilitate these discussions between individuals with dementia and care partners early. And whoop, just a second. Okay, wait, as soon as somebody else comes, it zips, so hold on a second. And I'm hoping to see these discussions will be initiated more often in community and healthcare settings. It's so hard for care partners to have to imagine what the person would have decided when they are no longer able to say themselves. So then Sarah, and then I'll go back. Joanne has another comment too. So Sarah first.
Yeah, okay. I wondered if people had an understanding of dementia as a terminal disease.
No, that is a very good question. No, a lot of them knew that, felt that dementia happens because persons age. It's part of the aging process. The terminal nature of dementia was something that was not appreciated by most of them, that people can die because of dementia. Right. It's just another condition that they have. Or somebody would say that, oh, I only have dementia. I don't have heart problems or anything like such. So yeah, this is interesting. Yes. Yeah.
Yeah, it's a funny one. And I know that some people feel like, based on this type of disease, people should only know so much information at certain times, and so it makes it kind of tricky. That's just a comment, but I imagine you might have been sort of in a tricky position with. Did you feel you were in a tricky position sometimes if questions came up?
No, actually, I did not feel that way, because I would capture those points when they would share with me in the session 1. So, and in the session 2, I would bring these things up, right? That dementia is not a normal part of aging process. Dementia is a condition that is irreversible. And in some cases, I would show them the picture of brain, of a normal brain, and compare it with the dementia affected brain. Somebody who is in the same age group as them, and that would sort of serve as an eye opener for them, that it is a structural condition that eventually leads to death, and the symptom burden of those in the advanced stages of dementia is very similar to somebody who's living with advanced cancer. So those conversations, those points, I would make sure that I would bring up in the second session for them to be more aware of the gravity of the situation. So
thank you.
I appreciated this. Yeah, thank you.
It's an excellent answer. Thanks.
Great. So Joanne has a really interesting insight here. I feel that the challenge in examining wishes is that early in the disease, values are based on living life most fully. And as the disease progresses, we find many people with dementia can find happiness and value in smaller ways that they may discount or dismiss before they get up to that stage. It's almost like asking a 20-year-old what they think is their criteria for quality of life, what they think their criteria for quality of life will be for their 80-year-old self. Many do not have that kind of insight. Wasn't there a rock song about, when I'm 64, I'll be dead kind of thing? Or like it's
yeah, no, you are absolutely right, Joanne. And that is a point of discussion in so many studies. You'll see in so many conversations, you'll see that what do you know when you don't know what can happen or what may happen. And we cannot stop having conversation about people's wishes because of that. But we do know that based on what the studies that are available so far, we do know that people who are put in the situation to make decisions for others feel comfortable in making care decisions when they're aware of the other's values and wishes. So it's all about preparing the trusted individual substitute decision makers for the times of crisis. And these are not legal documents. These conversations are not legal conversations, at least in Ontario. So people can make the best possible decision, keeping the person's best interest in mind in a given situation. So I think everybody found this valuable, but I'm sure people will make decisions. Everybody wants to do their best for the other. But when I engaged them in their values, I gave them 2 scenarios. One is when they're terminally ill, so that meaning they don't have any treatment options available. And the other one is they're in a vegetative state. And in those situations, what would they want for themselves if they need life-sustaining treatment, or if they are not able to feed themselves, or if they are in a lot of pain. So people were able to sort of think from that scenario perspective. But of course, later, you cannot really guarantee in terms of how they might feel when actually they get into the advanced stage. So yeah, that's a very good point.
Great. Well, thank you for a wonderful presentation. Now, everybody, it's really helpful if you fill out the evaluations, not just for us. We at the Institute, we love to have them, but also Shirin and all the other doctoral candidates need to put together a portfolio about their teaching, feedback about their teaching. So Susan just dropped it in. If you could just take a few minutes to fill it in, that's lovely for her as she goes out and job hunts in academia. If that's a good.
Thank you so much.
So thank you, Shirin. As you could see, fantastic discussion. Thank you, everybody, for sharing, either unmuting or putting your comments in. Really great discussion. And it's clearly a very important topic that is under-addressed in the general world, but particularly in the context of the pandemic, where people were concerned about and making these decisions at the, instantaneously. To have had that earlier discussion is really key. So thank you, everyone.
Thank you so much for your time, everybody.
Thanks. So it's just in the chat to get the JOT form.
Okay.
Looking for it. So you just have to press on the chat at the bottom and then it'll pop up. So thank you, and we look forward to seeing you at our next presentation, everyone. Take care.
Thank you.
Thanks. Bye.